About blood. Um, Blood's sort of an interesting topic, and depending on who you ask, it's either well within or without the standard ALS paramedic scope of practice to certainly continue it, but to initiate it. Again, depending on who you're actually asking about it. But there's a good chance that you at some point are going to be taking somebody from point A to point B if you do any sort of interfacility work at all. Good chance that you're going to take somebody who's got some blood running to go someplace. So you should probably know a little bit about it because, as I recall, we don't talk a whole awful lot about the actual process of like where did this blood come from? How does this blood get here? What's it doing in this bag instead of being in a person's arm where it started off? And then what are these other things that we give with it? And then, by the way, we've heard that there are like some really bad things that can kind of happen when you give blood, and some bad reactions. But does anybody really talk about that? Do you remember what we talked about? You probably talked about it if you're you probably maybe mentioned it in medic class, but like, what does it actually mean? What's the practicality of it? Let's hit on that stuff a little bit. So, the one thing I don't want to do is necessarily make the case like, oh yeah, whole blood versus packed red cells versus 1 to 1 to 1 versus 1 to 1 to 2 in trauma, et cetera, et cetera, et cetera. There's other people that like to talk about that like a lot more, and now that Ryan Hunter is coming back stateside shortly. We hope to get him next month, where he can pontificate on all the stuff about blood, yeah, because he's super passionate about it. But yeah, I don't want to talk about that sort of thing. I just want to talk about the actual process of the blood itself and what we all need to know about it, rather than making the decision about who should get what. But you do have to know a little bit about who should give what. How do you get blood from the blood bank? Or, sorry, how does the blood get blood? Or how does the blood bank, here we go, get blood from you or your family member and then turn it into stuff that you use? Blood is a sort of big business, and there's a network of blood banks and blood centers all across the country, and they're all doing stuff, and they all sell stuff back and forth and trade stuff and all that kind of stuff. What happens is when you take a unit of blood or a donation of blood out of a patient, what generally happens is it gets turned into components. Not all the time. Sometimes you leave the blood as whole blood, one bag of blood itself, but most of the time it gets turned into components. Why? Because if you leave it as whole blood, then that one person's donation has to go kind of all across, wherever it goes. It has to stay that way, and you can only be used as whole blood if you don't break it up into components. Which you may say, well, it's good, but not everybody needs whole blood all the time. So you can sort of break it up into the things that people need and selectively administer the things that people need is the idea of breaking it into components. One donation can generate, stuff for a number of different people rather than just like one bag of whole blood, stick it up there, and it goes into one other patient, and that's all you get out of it. So that's the idea behind components. What are the components themselves? Typically speaking, what you see is them broken down into red cells, or PRBCs, packed red blood cells, plasma and platelets. The way that this all happens is that they take the bag of blood that comes out of you at the donor center, and they spin it kind of slowly, and that separates out the red cells from the plasma and the platelets. Then they take the bag that is now full of plasma and platelets, they take the red cells and they go put them someplace else for use as red cells. And then they take the plasma and the platelets and they spin that faster, which separates out the platelets from the plasma. And you get just kind of a little bit of each one. And then they put those in separate bags. And so you have components of PRBCs, plasma, and platelets. The plasma, they may leave that out, and you've got about 30 days to use the plasma itself if it's not frozen. But if you freeze it really quickly and then thaw it out later, you can keep it for up to a year. So it's a little bit nicer to freeze the plasma, and that's where you may see the term fresh frozen plasma. That's plasma that they have taken, they separated out the platelets and the red cells, they froze it, and then they thawed it back out, and then you use that, and that just allows you to store it for longer. But fresh plasma you can keep out for like 30 days or something like that. The platelets themselves have a pretty short half-life, or a pretty short shelf life of like 5 days or something along those lines. Red cells are 2 weeks, 4 weeks, something like that. Several weeks, but platelets get used up pretty quick. Long story short. What might you do with this stuff? Well, broadly speaking, when you need red blood cells, you get a transfusion of red blood cells, either apheresis cells or PRBCs or whatever. You get red cells. If you need things like maybe volume or coagulation factors specifically, either because you are anticoagulated or something like that, you can get plasma. And if you need platelets, you get platelets. Sort of makes sense, yeah. A little more in-depth into who gets what. Trauma patients, generally speaking, again, this is not an effort to influence you in terms of like, you need to select this, this, or this, or make a case for it. Trauma patients are generally losing blood. They get transfusions for loss of blood, and usually they're losing all three products at the same time. They're losing red cells, they're losing plasma, and they're losing platelets. So if you think about transfusing that entire thing or a unit of whole blood, you're just replacing that blood volume. So these folks may get all three. A lot of times you see trauma patients getting red cells, at least up front, because that's the stuff, that's the oxygenating thing that is being lost anyway. But you're also losing coagulation factors, you're also losing platelets, and so it makes sense that replacing all that in somebody that's actively bleeding is important. By the way, there are some other products that you can make with this stuff that I didn't mention before. There's a thing, for instance, called cryoprecipitate, which is basically you take plasma and then you freeze it, and as it's thawing, you can kind of collect off just a little tiny bit of some of the proteins, some of the coagulation factors that come out of it that you can treat for like von Willebrand's disease and that sort of stuff. But it's little small concentrated volumes of stuff that comes out of the plasma. More coagulation factors. I didn't mention that before. But anyway, bleeding patients tend to get all three of the above. If you are just losing red cells because like you've got like a chronic slow bleed or something like that, you may just get red cells. Plasma typically you will see used to reverse or to provide coagulation factors for people. These are platelets, I'm sorry. But so folks that are on chronic aspirin who have a bad head bleed, you may give them you may give them their platelets back in order to make their non-functioning platelets because of the aspirin work better. Likewise, there are some diseases where you lose platelets and you start spontaneously bleeding into your skin. You get purpura and that sort of thing. They may get some platelets as well. And then there's plasma itself. Which you use to commonly we're going to use to reverse folks that are anticoagulated, and theoretically this could be because you've got just terrible synthetic function and you're bleeding as a result of it, but usually it's because they're on warfarin or a iatrogenic anticoagulant essentially, and they have something like a GI bleed or something they need to go in to have a procedure, or they're actively bleeding and you need to stop it. Likewise, if they have a head bleed, you may give them plasma to give back those coagulation factors that have been taken away by the Coumadin, so that they stop bleeding as quickly. That's sort of the rundown of it. Again, platelets you give if platelets are bad. Plasma you give if coagulation factors are bad, or if you need some volume that's got some coagulation factors in it. And red cells, if you're losing red cells, you give those in one form or another. Blood transfusions are common. We do it pretty frequently. Probably, I don't know if I give somebody blood once a shift when I'm working in the emergency department or something like that, but it's probably something once every other shift or something along those lines. We find somebody that needs a unit of blood. Sometimes they need lots of units of blood. And we tend not to think that much about it when we're doing it. Like, okay, he needs blood. And we think of it just like any other medicine. He needs blood. He needs, amiodarone, something like that. It's just medicine, right? But it's really actually pretty complex, the stuff that your body, the whole transfusion science, the ways that we kind of keep your body from attacking the things that we give it. Because you take somebody else's body, you take an organ, a piece of an organ, i.e. blood, out of one person's body, and you stick it into somebody else's body, and then you hope that the other person's body doesn't kill it. And that's basically the science of transfusion and transplant and that kind of stuff. So it's really kind of remarkable, and I sort of think about it like, if you remember in the first Star Wars, where like the little shuttle, they're like flying into the Star Destroyer, and you're thinking at any point like, oh man, that giant spacecraft could just absolutely kill that thing. That's sort of the way that things go in terms of transfusions as well. And there's a lot that goes into making sure that you sort of camouflage those donated blood cells so that your body doesn't attack it, and to some extent so that they don't attack your body. And that's where we get into talking about things like transfusion reactions. Transfusion reactions are bad things, and you worry about it. And again, why do they happen? Usually because you're taking something that is part of somebody else and injecting it into another human. If you think about that on a natural scale, what's the only time that would happen in the wild? Well, the only time that would happen out in the wild is when you got an infection of something. Some sort of bacteria gets inside you. That's what your body would think of it. So there are a lot of things that can happen as a result of reactions to the blood and the blood products, although thankfully they're relatively rare. One of the worst parts about a transfusion reaction, of course, is the paperwork that you have to fill out afterwards, and there is potentially a lot of it. Yeah, that's a joke. All right, but seriously, whenever there is a reaction, there's a lot of paperwork involved. There's a lot of things that happen, like we got to investigate. We got to make sure that this is actually the right blood, because one of the big things that we'll see is that one of the big problems with it is clerical error. One of the main causes for some of the severe transfusion reactions happen as a result of just clerical error. And again, thankfully, they are not very common, but when they happen, that's probably partly why the blood bank is filled with people who, if you think of the most anal retentive person in your service, the guy who you do the straps on the stretcher and then he goes back and redoes them even though there's nothing wrong with them. They look perfectly fine before, and then he also folds the sheet, and then he also goes back through and redoes the bag. That guy is everybody in the blood bank, because they want to prevent the possible complications that come with even just like a wrong misplaced number or something like that on a bag. So that's what you got when you deal with folks in the blood bank themselves. Let's talk about some of the reactions themselves. I think I'm good to kind of come back up there. There I am. All right. Oh no, it jumped over. All right. There's a number of different types of reactions, and we'll kind of hit on each of them and what they look like and when they might happen, that sort of thing. So, the bad one, the one that we often sort of think about, the hemolytic transfusion reaction. It's too bad that you're not seeing the rest of these, that the animation didn't work out real well. To sort of dissect what would have been this graphic here, think of all your blood cells. We've got your blood type A, type B, type O, O positive, O negative, et cetera, et cetera. That all refers to antigens that sit on the outside of your red blood cells. So if you have type A blood and you have blood cells that have the A antigen sitting on the outside of it, your body won't make antibodies to that A antigen, right? Because if it did, it would destroy all your blood cells. So it doesn't make antibodies to those. But it would make antibodies to B antigens or something like that, because those aren't in your body. Likewise, if it did, if you had B's sitting on the outside of your blood cells, then you had B antibodies, they would try to destroy your blood cells. So what becomes a problem? Well, heck, you know what? We got a second. Let me just let me add one thing here. Sorry, I'll show you what I wanted to. I'll show you what I wanted to show you after all. Apparently, no, I won't. Never mind. All right. We'll make it work anyway. So the problem is that if you take, if you've got type A blood, you've got type B antibodies to it. If you inject cells with B's on them, then your body recognizes that as like, oh, this is a foreign thing. This isn't the type A blood that we're used to seeing. This must be, a bacteria. This must be something bad. Go get them antibodies, and it sends the antibodies out. The antibodies attach to it, and they mark it as a thing for destruction. They cause it eventually to lyse, and they initiate an immune response to it. Of course, now they're all going to work. There we go. They initiate an immune response to it as well. So you essentially get like sort of a sepsis type picture, as well as hemolysis of your blood cells. And this can be a really marked thing. Like you start bleeding from your IV site, you get a fever, you can get hypotensive and really sick while getting this blood transfusion if you get the wrong blood type. And this was probably what killed a lot of people when we first started talking about blood transfusions. If you just happened to guess right and transfused, one person with type A blood got type A blood, or a person with type A blood got O blood, which doesn't have any antigens on it, then it worked out okay. And then probably for a while it was a real mystery why some people would do a bunch better, like they'd restore their vim and vigor and they'd be walking around the next day just fine, and other people horribly died within a couple of minutes after getting these reactions. Probably it was because of these hemolytic reactions, and this is essentially you're getting the wrong type of blood. What does that look like? Say you're transporting somebody, they were just initiated on some red cells. They're being taken someplace that has GI coverage for their GI bleed, so they're getting some blood transfusion. All of a sudden, these folks develop a fever, and most of these reactions are going to start with some sort of development of one of two things. It's either fever or hypotension. But these folks get fever, they get chills, nausea, their IV site starts to burn, they get arthralgias, and they get soreness in their back. They essentially look like they get septic all of a sudden. They get tachycardic and tachypnic, they can go into shock. They also start to develop, if they have, say, a Foley catheter in place, you notice that they start to develop really dark urine, and that's from the red cells lysing, from being, sheared apart, torn apart. That turns your urine brown color. And again, you can start bleeding from your IV site, you can develop DIC, a really, really bad thing with a high morbidity and a high mortality to it. And again, why is that happening? Because you're initiating an immune response to the wrong type of blood. Your body thinks that it is being overrun by bacteria in the form of these donated blood cells. What happens when, and again, what's the most common cause? Most common cause of this particular transfusion reaction is clerical error. The blood gets labeled wrong. A number gets transposed or something like that, and the blood gets labeled wrong, which is a really bad problem. What do you do if that happens? You've got a person that is being transported. Again, you're running down the road, and all of a sudden they start bleeding from their IV site. They get a fever, they get hypotensive, that sort of stuff. Well, number one, the key to all this is going to be, if you develop a problem, stop the transfusion, check the bag, make sure that it is actually what the person's supposed to be getting. And then one of the big things with this one is start running saline in there. What you're trying to do is preserve renal blood flow and help to flush out some of those cells so that they don't develop renal failure as a result. These folks may need things like, again, volume replacement. They may go on to need dialysis. They may need pressors in the meantime. So if they get real hypotensive or they go into shock, treat them as they would in shock. Pretend this is septic shock, essentially, although there's not necessarily a bacteria there. So these guys get fluid. Sometimes they get pressors. Push-dose epi would be the thing to do. And again, if you start to develop any problems during the transfusion itself, the number one thing is stop the transfusion. That's probably the key goal. Although at that point, the reaction's already happening and you need to treat it aggressively afterwards. So that's the hemolytic reaction. There's these other things too. As I said, a lot of these complications are going to start with a fever. If you're not constantly measuring a fever, or if you're not constantly measuring the patient's temperature, you'd never know about it. So that's why they, some of the guidelines are like, you got to check temperature every 15 minutes, something like that. You're making sure that these reactions don't happen. There's another reaction where you get a fever, but you don't actually start hemolyzing your red cells. It's a reaction. This is probably a reaction more to the cytokines that have built up in the blood cells as they've been kind of sitting on the shelf, hanging out. They continue to kind of build up little inflammatory things with it. And when you toss that into a patient, they get a little bit of a fever as a reaction to it. Sometimes it's a little more, but and there's other folks that say well, it's probably actually the leukocytes, blah 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 blah. Long story short, this is different than the bad wrong blood type reaction itself. Just a fever itself. If it's just a fever, and you may feel a little bit malaised with it. If it's just a fever, then it's actually not a big deal. You stop the transfusion, you let them sit for 15 minutes. If nothing else is happening, then it's actually probably okay to continue the transfusion at that point, and then get like a little Tylenol or something like that. Although, again, you have to watch out, because how do these things start? Often with a fever, as things are starting to progress real bad. But if it is just a fever itself, not that big a deal. They really shouldn't have like a lot of respiratory distress or anything like that, but sometimes people complain of a little bit of feeling of it, a little bit of tachypnea just as their temperature goes up. What do you do if you start developing a fever? Again, you stop the transfusion, and in this case, you'll look for anything else that's going on. Are they bleeding from their IV site? Are they complaining of back pain, arthralgias, anything other than, a little bit of malaise and like I feel cold, like you do when you get a fever, something like that. If anything other than a fever, it's probably not that like non-hemolytic reaction. You got bigger problems. But if it's just a fever itself, you can monitor them for about 15 minutes or so, and then oftentimes you can actually restart the the product itself. Although that again takes a little bit of gumption to do, to say, well, I had this little reaction, I don't know. A lot of folks get that unit discontinued, at least for the time being. But it probably is actually okay. If there's any question at all, of course, the thing to do is to have a medical control physician that you can talk to and ask about it and run by, who may say, well, yeah, he really needs that blood, go ahead and start it again, or yeah, let's just reassess when they get to the receiving facility, something along those lines. But if they get a fever, stop the transfusion, check the bag, and look for any other signs that something else is going on and treat accordingly. How about anaphylaxis? You hate the idea that you can get an anaphylactic reaction to something that your body already has in it, i.e. blood, but it certainly can happen. They're not like super common or anything like that, but they do happen. A true anaphylactic reaction. These are probably actually in folks that have a deficiency of like a congenital IgA deficiency, essentially an antibody deficiency, who are then exposed to those antibodies when you give them the blood the first time, and then they become anaphylactic to it. It's like they're getting penicillin essentially, and they have a penicillin allergy. You actually are probably allergic to some of the antibodies in the donor blood. And how does this look? This looks like anaphylaxis. It involves a number of different body systems. It can have GI distress. You can have wheezing and respiratory distress. You can develop urticaria. You can become hypotensive. And again, it's anaphylaxis. It is exactly that. What do you do if you are starting to give somebody transfusion? And usually this occurs within like a couple of seconds after starting the thing. Again, it's a really profound reaction sort of right away. It usually happens after just 10 cc's of blood or something like that to get into the patient that this begins. In that case, well, number one, again, stop the transfusion and then treat them as you would for anaphylaxis. So pay attention to their ABCs, give them oxygen if they need it, give them 0.3 milligrams of IM epi if they need it. Benadryl, steroids, IVF, and again, the treatment for anaphylaxis is epinephrine. It's IM epinephrine. That is the real treatment for anaphylaxis. The Benadryl, the steroids, the fluid you can give, but the treatment is the epinephrine. So if you're going to call it anaphylaxis, you need to be giving them a shot of epi, which most people will tolerate just fine. You can get just urticarial type reactions, though. If you get just itching, if you get just an urticarial rash on your skin and no wheezing, no respiratory distress, no swelling or anything like that, no other signs, if it's just an isolated urticarial reaction, that's another where you could stop, give Benadryl, and then theoretically 15 minutes later, if nothing is going on, probably start the transfusion again. But if there's any question about it, again, call for medical control. And if you don't have somebody you can call for medical control, find somebody you can call for medical control, because there's not a small chance that you will have to transport somebody getting blood someday, and you need to have somebody you can bounce stuff off of if even you think you're doing okay. There's this thing called graft versus host disease, which you usually won't see in terms of like while the person's getting transfused as you're taking them from point A to point B, but you may hear about it later on, and you may just say, well, what the heck is that? It is a transfusion reaction, but here's the thing that goes with it. Typically speaking, you are going to get a few lymphocytes, a few immune cells in your transfusion. And typically speaking, your body looks at it and says, well, that is not a normal thing, and it will destroy those immune cells. However, if you don't have immune cells of your own, then those lymphocytes, those immune cells that are being transfused into you, actually will look around and say, well, wait a minute, these aren't our cells. Let's get them, boys. And can actually begin to attack the host organ itself. So you are injecting lymphocytes that then begin to attack you, and that just sucks. It's absolutely a terrible thing. And it's got a high morbidity and a high mortality to it. It's got like from blood transfusion, the number I could find was like an 80% mortality for bad graft versus host disease. Now, there certainly are folks that get it from other things, things like bone marrow transfusions or bone marrow transplants you often see, sometimes in transplanted organ otherwise. Essentially, those cells go out and they start attacking your body, and so you get problems with whatever area is getting attacked. Sometimes it's the liver, sometimes it's the GI system. These folks tend to get fever, belly pain, they get a lot of diarrhea, they don't want to eat. Skin is a common place for it. It can progress from just a nasty rash to full TEN, toxic epidermal necrolysis, where you're developing blisters and your skin peels off, and it's potentially bad. Not everybody gets that way, of course, but it can get really bad, like essentially a terrible burn that your body is doing to itself. You get tenderness over your liver and a big swollen liver, that kind of stuff. Now, again, the good news is this is pretty uncommon. This is like out of, I think there's something along the lines of, in 2015, 17 million blood product transfusions in the United States, and 1 incidence of graft versus host disease was recorded, which is pretty good. The odds are with you. But man, for that person that happens, like, man, that really stinks. And again, why does this usually happen? It's folks that are immune suppressed, that don't have lymphocytes to go out and take care of those lymphocytes that get put into your body, that get transfused into you. All right. One of the more terrifying transfusion reactions, the ABO incompatibility, the hemolytic transfusion reactions are one of them, but one of the more terrifying ones that you see a little bit more commonly often is transfusion-related lung injury, or TRALI, T-R-A-L-I. What happens here is as I kind of mentioned before, you get a few lymphocytes transfused in with your blood, typically speaking. A lot of times they will siphon off like most of those, but if you're not specifically requesting it, they don't necessarily get all the lymphocytes out of there. And so you can develop an immune reaction when your body tries to go and attack those lymphocytes, and it can be particularly strong. And the place where that manifests tend to be in the lung tissue itself. So if you have antibodies to lymphocytes and they attack it, you can get what to me looks like, well, it's an ARDS sort of picture, but sort of almost an anaphylactic type picture, but more just associated with the lungs itself. You get a lot of fluid building up in the lungs. You get increased vascular permeability in the lungs. And these folks go from sitting up, doing all right, getting their transfusion, no problem. Oh, man, I feel a little... All of a sudden, they go from, stats of 99% and feeling fine within a couple of minutes to gasping for breath with a bunch of lung secretions. You listen to them, they have RAWs all over the place. These folks can also develop some hypotension as well. Dyspnea is the primary finding in this one. So if a person is getting a blood transfusion, all of a sudden they say, man, I feel kind of short of breath, and they start coughing, that person is probably about to get pretty sick pretty quickly, and you need to be prepared to move kind of fast with it. Transfusion-associated lung injury itself is essentially an ARDS type picture, and you can treat it the way that you probably would treat ARDS. So you support their airway function. Non-invasive positive pressure ventilation is a great move. Early CPAP, early BiPAP on these folks. Sometimes you can get them through it. A not small number of these people do need intubation, though, because you will have high pressures. But this is not, this particularly, bear in mind, is not a fluid overload situation. This particular disease, it happens usually a couple of minutes to several minutes before the transfusion is finished. So a couple of minutes from the time that you start up till about an hour when the transfusion is finished, that's when transfusion-associated lung injury actually happens. So again, this is not a volume overload issue. This is a vascular permeability issue. So giving things like Lasix and trying to do like the CHF stuff in that way, not really all that helpful. This is the lungs themselves that actually need support. And supporting their airway, supporting their respiratory function is the way to make that happen. We'll talk about, by the way, I've got a thing about the timing of all this. You may be wondering about it, like when did these things start, or maybe you're not wondering about it, but I'll give you means to kind of identify some of these things based on when they start in just a second. So stand by on that one. Now, there are, some folks get massive amounts, transfusions of blood. You know, I think the definition is greater than 10 units of product in 24 hours. And folks certainly do get that. Sometimes they'll get 10 units of blood sitting down in an emergency department, let alone what they get when they go up to an operating room or an ICU someplace in the hospital. And there are complications that happen just by virtue of the fact that you're getting so much blood that you may run into. And if this may be the case where you're taking somebody from a level 3 trauma center up to like the mothership trauma center, or even a smaller hospital. If you happen to have a blood bank that has 10 units of blood and you give them all because the person is bleeding so profusely, these may be things that you might have to deal with in route. So, what's the stuff that can happen? Well, coagulopathy is one of those ones. And you may say like, well, but they're getting blood. Why are they bleeding as a result of me giving them blood? If you are just given red cells, then you're not including in, they're losing red cells, of course, but they're also losing coagulation factors and platelets. And so if you're just giving back a whole bunch of red cells and not replacing those other things, then they bleed because they're coagulopathic because they don't have them. So that's where the idea of like giving the platelets and giving the plasma or giving whole blood itself is a probably good idea. That's at least part of it. Likewise, you can run into problems because, I'll talk about it in a second. Anyway, coagulopathy happens more so if you're just getting lots and lots and lots of red blood cells without getting any other products with it. Volume overload is something that's out there. A lot of times you'll see this in folks that say they are cirrhotic and they have a GI bleed. And their hemoglobin is down to, 3 or something like that. And you think, okay, well, I need to give them a bunch of blood. Well, yeah, that's true. But the problem is that they already have lots of blood volume. They just don't have a lot of red blood cells. So if you throw in 3 or 4 units of blood, that's 400 cc's per unit or something like that. You now give them a 1,600 milliliter bolus of some kind of fluid that will actually stay in their vasculature. And you took what was a person who was a little bit volume overloaded to start off with, and now they're a lot volume overloaded. So trying to replace their blood cells without taking into account the fact that they also need to kind of switch out that volume for blood cells is how you get volume overload. And it basically looks like CHF, essentially. You get pulmonary edema. It sort of looks the same way. Some of these folks, that's why you'll see them started on diuretics while they're getting their lots of blood to help pee out the liquid part so you can take in the red cells. Hypothermia certainly happens because we tend to just kind of let this blood hang up there and not put it on a warmer, but it came out of a refrigerator at 33 degrees or something like that. Or maybe it's 40 degrees, but it came out of the refrigerator. Now you're dumping it right into the person. If it's not on a blood warmer, they're going to get hypothermic after just a couple of units just by virtue of you sticking it in there. So all this stuff needs to be on a blood warmer. You can get hyperkalemia just because the red blood cells, the stuff that we transfuse folks tend to be a little fragmented, like gnarly bits of cells, and so you can have a little bit of extra potassium in there. But if you're giving a lot of product with a citrate component to it, you can also get hypokalemia and metabolic alkalosis, I'll get it out, as well as low calcium. So you'll see a recommendation now that if you're giving lots of citrated products, like red cells, like a whole bunch of red cells, you should start replacing their calcium as well. And that can be done with calcium chloride or calcium gluconate. But after you get 2, 3, 4 units in, they really ought to be getting some calcium with it, because you're probably taking a hit on your calcium level. That's all the stuff, again, that all just happens as a result of getting the volume of blood that they would. Most of that is fairly straightforward. If they're volume overloaded, either give the stuff slow, or they can get a dose of Lasix or something like that. If they're hypothermic, warm up the blood. Treat everything the way you would. All right. One last thing to sort of mention here. The timing of this can help you sort of identify what sort of reaction you have. So things that happen relatively quickly, from the time you start the transfusion, a few seconds, 10 cc's of blood in, something like that, is typically when the anaphylactic type reactions will start. Again, what's anaphylaxis? It's anaphylaxis, GI distress, hypotension, wheezing, coughing. But also the minor urticarial reactions will often happen within a few seconds, because they're allergic type reactions. That's when they kind of kick in. The bad reactions are really the ones that you got to watch out for. The hemolytic reactions, the trolley, those things usually happen a few minutes in. It doesn't happen right away, but it takes a few minutes to kind of get established, but usually starts before the transfusion is finished, so within about an hour of starting it, generally speaking. And again, not every patient reads the textbook and follows that pretty well, but oftentimes you'll see that stuff happen before the transfusion is actually finished. Things like transfusion-associated overload, that may happen towards the end of the transfusions, whenever they get the requisite amount of volume that they actually start to get short of breath. So that may happen later on. And then there are some things that can happen long term, like if somebody got blood 3 hours ago, they can get a non-hemolytic febrile reaction up to 6 hours in. And then days to up to a week in is when graft versus host will actually kick in. So just kind of bear that in mind. That can help you sort out what sort of reaction may be going on. And again, you might treat things a little bit different. Although for the most part, you're going to provide just the same old good, essentially critical care that you would. If they look anaphylactic, you treat them for anaphylaxis. You give them IM-Epi. If they're wheezing, you give them nebulizers. If they have RALs or they're in respiratory distress, then put them on positive pressure. While the disease process itself is sort of important, more important is if you just if you can't remember any of this disease stuff, just remember, if they're in respiratory distress, consider positive pressure. If they're wheezing, consider bronchodilators. Treat anaphylaxis. And if they have hypotension, consider fluids and pressors, push dose epi, that kind of stuff. Then you can sort it out a little bit easier. And maybe everything I talked about for the last 30 minutes, maybe it's not all that important if you just remember the treatments of them. But it is good for everybody to know, and I think if you are transporting these folks, that you do have to have an idea of it. You don't have to know the thing. You don't have to be an expert in it, but you should at least know what could happen and know why it might happen at least a little bit, and know the basic steps to treat them. And again, that's support their respiratory system, support their hypotension, and if you run into any problems, stop the transfusion and call for help, ask for an assist. To sum up, blood products are really pretty safe. Out of, again, 17 million transfusions over the course of a year, there were only about 50,000 transfusion reactions, and most of them were the non-hemolytic febrile reactions. A little bit of a fever, but patient does okay. However, when it does happen, it can be rapidly fatal, and you have to be prepared to act on it. So be watching for it and be ready to act if need be, because it could happen at any point while the patient is getting their blood transfusion, and even a little bit after. Bad reactions are really bad. They usually are a combination of dyspnea, hypotension, and fever. And you can treat those in the way that you would always treat dyspnea, hypotension, and fever. Generally speaking, there's not that much about a blood transfusion itself that makes them separate. If the patient is short of breath, they can almost always get non-invasive positive pressure ventilation. Bear that in mind. And if you have any problems, stop and call medical control, and you can help sort it out. And it may be okay to continue that transfusion again if you've got a long way to go. But do that. Don't try to sort that out on yourself all the time. Load the boat. Make somebody else kind of answer that question as well.